So, good afternoon, everybody. Thank you very much for inviting me to talk. It's an honour to talk in Manchester. It's an awesome city. We split the atom here. We gave the world suffragettes. And now we're going to talk about the pelvic floor. I work in what I often describe as the basement of medicine, the pelvic floor. Anatomically, it's downstairs. Politically, it's downstairs, and it's a very underfunded downstairs. Even the term pelvic floor undermines its function because it's not a passive structure. It's an engine. It's a biological wonder. The pelvic floor is rarely discussed in public life. It's not glamorous. It doesn't attract billion-pound innovation funds, and it doesn't trend on social media. But for half the population, it determines whether you can run for a bus, laugh without leaking, have sex without pain, or grow older without shame. And yet it receives a fraction of all biomedical funding. So today, I want to take you into that basement and introduce you to some of the awesome structures, a powerhouse of functionality. I want to persuade you that Manchester is the place to host the Institute of Pelvic Health, grounded in history, energised by a vision of the potential future, and powered by you. Up to 50% of women experience some degree of pelvic organ prolapse in their lifetime. A third will experience urinary incontinence, and up to 20% will need to have surgery. And when they do have surgery, unfortunately, sometimes they can get a recurrence. So these conditions are not rare. When something affects half the population at some point in their lives, it's not a special interest. This is mainstream medicine. And the scale alone demands that we have better mechanistic science to inform our future treatments. But first of all, I want to set our problem in a historical context. 200 years ago, the Industrial Revolution brought Manchester to the forefront of the world. When we talk about the Industrial Revolution, we tell triumphant stories of steam and railways and steel and productivity and progress, great feats of male engineering. But there's a quieter story that we rarely tell, one that's not written on balance sheets, but in women's bodies. It was the cotton mills that developed with industry and developed huge wealth for the mill owners. The majority of workers in the cotton mills were women. They were working long hours, standing, lifting, coughing polluted air, living in cramped overcrowding with poor diet, undergoing repeated childbirth due to no contraception, and then they were straight back to work with no maternity leave. You can imagine the epidemic of prolapse that followed. And here in Manchester, where the Industrial Revolution began, we see prolapse developing. This shows a diagram of what prolapse really means. On the left, you can see the diagram of the normal pelvic organs in their correct places. And on the right, you can see what happens when prolapse develops. The vagina in the womb can descend. It can cause difficulty in emptying the bladder, which can lead to infections. It can lead to fecal leakage, and it can lead to the vagina or uterus becoming ulcerated if not treated. So in Manchester, two surgeons, Donald and Fothergill, in the 1890s, developed a safe operation for prolapse. Their operation is still performed today, not an eponymous operation like most were in the time. This is called the Manchester Repair. It carries our name. But this was a minor light in what would remain a pretty bleak terrain for women's health. So the women's health gap. Women, the World Economic Forum and McKinsey in 2024 found women live 25% more of their lives than men in poor health. Not because they live longer, they live longer unwell. Closing the women's health gap could yield 75 million disability-adjusted life years every year. I'm afraid that makes no sense to me. Some epidemiologists, I'm sure, will understand it. But in plain English, that means it's equivalent to giving every woman on the planet 7 additional healthy days every single year. It would also unlock $1 trillion in GDP annually by 2040. That's not a niche women's issue, but it does still exist. And we have to ask the question, why? Why is the landscape of women's health a little bit barren? Well, there are several reasons. It's not been studied adequately. Women don't get diagnosed properly. They're not treated equitably. We normalise their symptoms and we don't listen to them. I'll explain this a little more. If you go back in time to when anatomy was being studied, and right the way through until the 1990s, it's been the male form that has been studied. You'll be shocked to know that the clitoris was only fully described in its entirety back in 1995. Now, we've not studied women adequately. This is talking about the car industry and making cars safer. And you can see on the right, there's a bunch of crash test dummies. The only problem is that those crash test dummies are all men. They're all 6 foot something, and cars and car safety has been designed based on these male forms. This has led to cars not designed for women. So females are more likely than males to sustain a serious injury, even a fatal injury, in a collision. Heart disease, well, that's fair. Heart disease kills men and women equally. But in women, heart disease is not diagnosed as frequently as in men. If you Google a heart attack, fewer than 5% of the images you see will be of a woman. They'll all be of men clutching their chests. For decades, heart disease was researched largely in men. Male physiology became the norm. Women presented differently, and their symptoms were labelled atypical. How can something be atypical when it's 50% of the population? Women are more likely to report breathlessness, nausea, or fatigue, and they are more likely to be diagnosed with anxiety or indigestion than a cardiac illness. Even in cardiology, which is a mainstream high-profile condition, women are under-recognised and understudied. So if a bias can exist there, we should not be surprised that it exists in pelvic floor health. One of the other factors is that we normalise suffering. You go to any supermarket, you'll come across an aisle like this. The first half is Tampax and sanitary towels for periods. Now, one of the things you'll notice if you pick up a packet, it doesn't give any health information. I would suggest if you're picking up a packet that says super or extra super, it should have some health information on it about maybe getting help for your heavy periods. As you progress, you might move down the aisle and be picking up the other absorbent products. So you've gone from absorbing blood to absorbing pee. This is the normalisation of women's health problems. I would suggest that all sanitary products have some health information on them about other treatments and where you can access care. That way, together, we can change the world. Well, that brings me nicely on to somebody else who was quite radical. This is David Worrell. He joined as a consultant in Manchester in 1968. Radical for his time, he recognised that women with pelvic health disorders deserved a specialist, a dedicated person to look after their care. Elsewhere, women were fractured into silos. A bladder here under the urologists, a vagina over there cared for by the gynecologists. Bowels were somewhere else in another building with a colorectal surgeon. The pelvis was nobody's responsibility. David Worrell was one of the first to create a urogynecology department. Urogynecology, that's what I do. It's urology, it's gynecology, it's colorectal, and then say it quietly, it's orgy at the end. That represents the sexual function. So yes, urogynecology brought together in one specialty. Feels a bit audacious to place myself anywhere near the Great Manchester story, but the truth is I arrived here in 2001, a quarter of a century ago. But long before that, in the 1980s, I think, Tony Smith joined David Worrell and helped build this unit into one of the leading centres for laparoscopic pelvic floor reconstruction surgery in the world. Tony was my mentor. He taught me some things far more important than how to operate. He taught me to question everything, to build teams, not empires, and to remember that the cure always has to be better than the disease was. I joined as a research fellow. My job was to run the day-to-day multi-centre MRC-funded laparoscopic versus open cold post suspension trial, to make sure that we hit the recruitment targets, to collect the follow-up data, to do the pad tests, all that kind of stuff. But within that framework, I had to find my own research question for my MD. I was told that research was 1% inspiration and 99% perspiration. No one told me to pick an easy question, though. So the question I ended up asking was, what do we actually mean by cure? Not surgeon cure, not anatomical cure, but women's definition of cure. That question shaped everything that followed. Tony also instilled a discipline to don't do research to generate papers. Do research to answer a question that matters. So I performed qualitative interviews with a purposive sample of women, some of whom were cured both anatomically, subjectively and objectively of incontinence. But there were also women who were either cured subjectively but not objectively, or the other way around. Our findings challenge the assumption that cure is a simple binary outcome. When women ask, will surgery cure my incontinence? That question is filtered through an individual's coping strategies, their expectations, their activity levels, whether they use pads, whether they're toilet mapping, whether they're fluid restricting, what their lifestyle involves, and how much they'll adapt their lifestyle to manage their incontinence. These shape both the baseline severity and the perceptions of success. Within the MRC trial framework, we also compared disease-specific outcome measures. We demonstrated, using psychometric tests, that different instruments captured different constructs, and that anatomical or pad-based definitions did not reliably align with women's own definition of cure. Cure, therefore, is not a fixed surgical endpoint. It is an outcome mediated by the women's own context. We've yet to work out how to measure that, but I'm hopeful that with modern AI, machine learning, and you lot out there, you may come up with an instrument that could be developed to effectively measure cure. This has important implications for trial design, outcome selection, and shared decision making. If we measure the wrong construct, we risk misclassifying both success and failure. We need to be looking at the individual woman, not the average. We need big data, we need more mechanistic research to find the right operation for the right patient. In 2021, we conducted a questionnaire-based study examining public understanding of the female genital anatomy and pelvic organ prolapse. The findings were quite sobering, and it caught the attention of the BBC, The Guardian, and a few other news outlets. Fewer than 1 in 10 participants who filled in the questionnaire in our hospital in general clinics could correctly label all major external genital structures on the diagram. Just over half reported any understanding of pelvic organ prolapse at all, and even among those who believed they understood prolapse, only a minority could identify that the main symptom was a vaginal bulge or lump. Very few recognised that physiotherapy was a treatment option. This matters profoundly. If women do not understand their own anatomy, they may normalise symptoms, delay seeking care. If they don't understand the condition being treated, informed consent becomes fragile. And if they can't conceptualise the pathology, shared decision-making inevitably is constrained. Health literacy is not an optional extra in women's health. It's foundational to ethical practice, to realistic expectations, and to meaningful outcomes. If we want better research, better trials, and better care, we must start with something very simple. Women deserve to understand their own bodies. Coming back to our list, one of the reasons the landscape of women's health research is barren is that women are not listened to properly. I think this is possibly the most insidious and prevalent problem. This slide reflects one of the most challenging moments in contemporary pelvic floor surgery. In 2020, the Cumberledge report was published, First Do No Harm. It concluded that a central recurring theme across several medical interventions was no one is listening. In the context of urogynecology, this referred particularly to the use of synthetic midurethral tapes. These tapes are a narrow strip of polypropylene mesh placed under the midurethra to treat stress urinary incontinence. The principle is simple. They replace the pubourethral ligaments. Yeah, we could argue about that for a long time. Anyway, the principle is simple. Restoring continence when the intra-abdominal pressure rises, when a woman coughs, laughs, sneezes, exercises. For many women, these procedures were highly effective and life-changing. For the NHS, they were groundbreaking because it was quick day case surgery that most surgeons could learn easily. However, a small but significant group experienced serious complications, chronic pain, mesh exposure, sexual dysfunction, and neuropathic symptoms. And many described feeling dismissed when they sought help. The report includes powerful testimony from the women. Quotes such as, "I've had a constant battle to get the help and treatment I needed." The women talk about gaslighting, they talk about fobbing off, and they talk about this culture being rife. That language is difficult, but it reflects their lived experiences. And the lesson is about systems. Innovations without long-term surveillance, the use of a blanket one surgery fits all, consent without full uncertainty being explained, outcome measures that didn't capture pain, and cultures that fail to respond quickly when patients are harmed. For those of us working in this field, the lesson is not that surgery is inherently wrong. Midurethral slings have a strong evidence of efficacy based on good quality, large randomized trials and long-term follow-up. For me, it's not about abandoning surgery. It's about strengthening the science. It's about working out who is safe to have a tape and who isn't. And then it's about strengthening the trust between the doctors and the patients. And that takes me on to my current research. This is some of the pictures of our team doing more exciting things. And the current Worrell unit. The Worrell unit is now the largest urogynecology unit in the UK. We treat women with prolapse and incontinence from the local area of Manchester in 4 hospitals: Trafford, Wythenshawe, Central Manchester and North Manchester. We have tertiary services for complex recurrent operations for women from across the Northwest. We have nurse-led services as well as consultant-provided services. We also are a supra-regional service accepting people from Northern Ireland and even as far away as Bahrain for psychovaginal fistulae and mesh complications. We're now staffed by 6 subspecialist consultants, 6 specialist nurses, 3 clinical scientists, and 5 clinical research fellows and 1 senior resident.